Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Grand Rounds this week, where Dr. Megan Surkan, a geriatrician and assistant professor at the University of Saskatchewan, presents on frailty in the perioperative period. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
Thanks everyone for joining in today. Today I'm going to talk about frailty in the perioperative setting. So I have nothing to disclose or conflicts of interest. And in terms of, what are we going to talk about today? Try to keep it simple. So first we'll look at defining what is frailty, and it's sort of a more complex concept. So we'll spend a bit of time on that, and then its relevance and evidence for perioperative care. We'll look at some current evidence and guidelines around frailty measurement in the perioperative setting, review a few different ways of measuring frailty, because there are dozens out there, but some that are more relevant to perioperative settings, and sort of pros and cons of each. And then what I'm most looking forward to is sort of a discussion around how do we do this now, and go over how it may benefit patients. So to start with, I thought it'd be good to start with a case. This is a not exact replica, but very similar one that I've been consulted on post-operatively. This gentleman was a 71-year-old type 2 diabetes, not the best control, BPH, daily smoker, diagnosed mild cognitive impairment, so short-term memory loss, but not yet affecting function, hearing loss, and he was also taking some amitriptyline for sleep, mood, wasn't really sure. He first presented to his family physician with 40 pounds of weight loss, a hemoglobin of 80. Unsurprisingly, it started falling, and was ultimately found to have esophageal adenocarcinoma that was localized. So he was scheduled for OR, underwent resection, but his post-op course didn't go so well. He got a bed sore, pneumonia. He wasn't able to eat very well, of course, so an NG tube was inserted, but because he had risk factors for post-op delirium, he started pulling at the tube, got restrained, also developed an ileus, and then he was given multiple medications like Gravol, lorazepam, haloperidol, became quite delirious, also suffered with urinary retention with the pre-existing BPH, had a Foley that got infected, and then all said and done, he wasn't able to walk out of the hospital and had to go to long-term care. So we'll jump back to that at the end, and kind of I'll try to frame what could we maybe have done differently to change that trajectory. So to start with, we'll just talk about what is frailty. So a very simple definition: frailty is a multi-dimensional state of impaired physiological reserve attributed to an accumulation of deficits, usually related to both aging and disease. It's not simply present or absent, and this is something I see fairly commonly, that people are like, oh, well, they're frail or they're not. It's sort of like if you think of heart failure or CKD, you would care if someone had a GFR of 50 versus 10. So in the same way, we care that frailty, is either severe, moderate, or mild. So there's a spectrum of how severe it is, which has implications for management. Really, frailty is increased vulnerability to suffer poor outcomes from an acute medical stressor, of which surgery is a, not always planned, but sort of something we can anticipate as a medical stressor. And vulnerability inherent to frailty results in higher likelihood for adverse surgical outcomes. So these outcomes are both patient-related and then system-related. So patient factors overall, so all comers that are frail that undergo surgery, there's doubling in the rates of morbidity, mortality, loss of independence, and patient-reported disability. And then on the healthcare system, increased length of stay is a big one, and greater likelihood of discharge to institution or protracted stay at a rehab facility. This is just sort of quick diagram of on the left here, if someone is not frail, so they're robust, you can see their physiological or homeostatic reserves are very robust. They have no pre-existing stressors or medical conditions, functional impairment, malnutrition, sarcopenia, what have you, impacting their ability to recover. So this person's probably going to do quite well. In the middle, you see this person might have some mild frailty. They may have difficulty, doing sort of heavy housework or, mowing their lawn or going up several flights of stairs, but they're still overall fairly independent, and, may have a few medical conditions that affect their function, and exercise tolerance. So this person has some degree of frailty, but also, it looks overall more resiliency. So they likely would do, middle of the road, hopefully okay with most surgeries. And then if you look at someone who's overtly frail, and this would be more severely frail in this diagram, they have more stressors or more physiological reserves that are depleted than homeostatic reserves remaining. If this person underwent a major surgery, you could likely predict that they would have an unfavorable outcome. Frailty, we'll get into some ways of measuring it that I think helps sort of understand more what it is. But in general, there's, as I said, dozens of frailty measurement tools out there. Generally, they incorporate 4 key components, and sometimes not all at once, but these are the 4 areas that frailty looks at for those accumulation of deficits. So comorbidities and the severity. So, if someone is MRC class 4 from their COPD versus, they've never had an exacerbation, have no limitation on their, exercise from dyspnea, exercise capacity. So there's usually some measure of physical performance, whether it's like gait speed, timed up and go, grip strength, what's called a short physical performance battery. There's all sorts of ways of measuring exercise capacity. The big one is functional independence, so instrumental and basic activities of daily living. This is sort of a trickle down of all these other things combined. If someone, is frail, they're not going to be able to lift, 3 huge bags of groceries up 4 flights of stairs. That kind of combines your exercise capacity, comorbidities, nutritional status all in one. And then the final one being some measure of nutritional status, whether it's unintentional weight loss, sarcopenia. There's usually something to do with nutrition in a frailty measurements tool. So this is sort of a recapitulation of that in visual form. So you could imagine if you had a 70-year-old that looked like this gentleman in the wheelchair and a 7-year-old that looked like this gentleman running a race, they may do very differently after surgery. And then the other thing is age-related sarcopenia. It's not inevitable, of course, if you're active, you can prevent it. But, if this 74-year-old sedentary man spends 5 days not getting out of bed post-operatively, you can imagine he's going to probably not be able to ambulate, or it would be a long road back to be able to walk again independently versus someone who has a lot more reserve with their strength and functional, muscle mass in their lower extremities. Another thing I wanted to mention, I know I was supposed to focus on physical frailty, but I can't help myself to talk a little bit about, other aspects of frailty and recovery with older people. So the term frailty typically has referred to physical frailty or characteristics. But there is more and more talk in the literature about cognitive frailty and social frailty. So cognitive frailty essentially is someone who might have pre-existing MCI or dementia or, cognitive impairment. And it's something we know increases risk of post-op delirium. And then social frailty is another aspect that is getting more and more recognition. So someone with poor social support, likely this could impede post-op care instructions, nutrition, adherence, or affordability of transport, back and forth to appointments or taking prescribed medications. So these are sort of aspects in someone's overall likelihood of a poor outcome that I think should be considered as well. In terms of the first frailty measurement tool, I wanted to start with the Freed. So Linda Freed in 2001 came up with this physical frailty or frailty phenotype that she described. where there's 5 different elements to this. And if you have 2 of these, you're considered pre-frail. If you have 3 or more, considered frail. So unintentional weight loss defined as around 10 pounds in a year, self-reported exhaustion or fatigue, weakness, and they use grip strength to measure this, slow walking speed, and low daily energy expenditure or physical activity. So that's sort of the first, way that frailty was defined. As I mentioned before, so frailty, it's relevant, is it there or not, but also how severe is it? So quantifying is this mild, moderate, or severe, and the clinical frailty scale does a really good job of this. So we'll get to that in a bit here. I really like the gas tank analogy. I find this helps people understand, or patients, and their families understand what we're talking about. So if you imagine, you have someone, let's say they're in their 40s, they have really no medical conditions, they're fully functional, independent, don't need any help, good nutritional status, not sarcopenic. They have a full tank of gas and they have the same distance to drive. So let's say 100 kilometers. If you have that person, let's say 45, 40, 50 years pass and they're now 80 or 90 and they're undergoing a surgical procedure, but they've developed multiple medical conditions. They've been unintentionally losing weight. They're fatigued. They need a lot of help with day-to-day things. Like they might even need help with things like getting dressed or bathing. That person, might have a quarter tank of gas and they still have to drive 100 kilometers. So you can imagine that someone starting out with less physiological reserve essentially is not going to do as well. This is the Rockwood Clinical Frailty Scale that many of us are likely familiar with. So it's got 9, potential options here. So 1 to 3, someone is not frail, and then 4 to 9 is considered frail. And really, anyone who's a 9, we probably shouldn't be taking to the OR unless it's a symptom relieving procedure. For very mild frailty. So this is someone who, they'll say, I'm not walking as quickly, I'm slowing down. I have to stop to catch my breath. But they're still independent with everything that they're doing. A CFS of 4 is very different than a CFS of 7, where someone is confined to a bed or wheelchair. They're no longer ambulatory. They need help with dressing, bathing, sometimes feeding, pericare. So those are very different aspects of frailty. So the scale is really nice for delineating how severe the frailty is. So that's just sort of a brief intro to frailty. And then the second part, I wanted to just look at what are the guidelines and current evidence say we should do. And I'll focus on, the 2 most robust guidelines are the American and British guidelines. So I'll kind of focus on those. One thing too, just to keep in mind when we're looking at evidence review of frailty, that there's a lot of different frailty scales out there, and across worldwide, there's not a full consensus of how best to measure it. Most guidelines talk about the clinical frailty scale, but because there is some heterogeneity in how frailty is measured in the literature, it's sort of difficult to capture what quote unquote defrailing interventions are beneficial and to what extent. This is sort of an overview of what's out there. The British Journal of Anesthesia published earlier this year a systematic review of periop clinical practice guidelines in older people with frailty. So should we measure frailty in the perioperative setting? As per this, yes. They identified 8 current clinical practice guidelines that do all recommend measuring frailty as a routine practice in older surgical patients. And, the goal of identifying frailty preemptively, is preventing or decreasing the effect of negative outcomes of surgery, things like post-op delirium, loss of mobility and independence, malnutrition, death, length of stay, discharge to higher level of care would be the top 5 there. So starting with the American Geriatric Society and joint with American College of Surgeons guidelines. The most recent ones were in 2016, and essentially what they recommend is a comprehensive geriatric assessment. So they look at things like they recommend measuring nutritional status, functional status, frailty, cognition, and polypharmacy. essentially. And, if we identify these sort of frailty components from there, they talk about things like a CGA or geriatrician consult, nutritional support, early mobilization in place, planned to be in place postoperatively, early allied health referrals, comprehensive discharge planning. And it doesn't give us a specific tool actually to measure frailty, but they do sort of outline that this is very individualized, which is what a CGA does. More recently, the British Geriatric Society, joint with the Centre for Perioperative Care, CPOC, came out with guidelines for a whole frailty pathway, essentially, for older people undergoing either elective or emergency surgery. So I'll flag standards 3 and 4, but I also will mention 5 and 6 because it's relevant to delirium. So if you see standard 3, all patients over 65 referred for elective or emergency surgery should have frailty status documented at referral, peri-op assessment, and admission using the clinical frailty scale. And then from there, people with a CFS score of 5 or above should undergo a CGA prior to surgery, which, I think would be ideal and fantastic. It's just in Britain, they have many, many more geriatricians. I believe more geriatricians than general internists. So the practicality of everyone undergoing a CGA, with our sort of workforce in Canada is sort of something I'll talk a bit more later. And then standards 5 and 6 here, they also say everyone who is frail should have their cognition tested prior to surgery, and all hospitals should have a delirium management protocol specific to the perioperative setting. So this is the pathway. Again, you can see it, essentially every aspect of this, they talk about measure frailty. So it's quite a bit, that this is much more than we're doing now. So, but they actually, if you see here, it's kind of nice. So they have, either the route or pathway of primary care, it's a referral for elective surgery, or this is an emergency surgery, whereby they recommend the clinical frailty scale. But I wanted to talk about the electronic frailty index just briefly. That's another sort of tool for measuring frailty. So what this is, I believe there's 36 different frailty components in here. It's another accumulation of deficits type model of frailty. And you take the number of deficits someone has. So let's say they have respiratory disease, osteoporosis, they have some cognitive problems, hearing loss. So they have 4 or 5 different things. So you take 5 divided by 36 and it spits out an index of how, mild, moderate, or severely frail someone is. And the thing about this, though, I wish we could have something similar here, but in the UK, the EMR used in all primary care clinics actually has this built in automatically to be calculated without any extra effort. So based on data points entered just on routine interactions with the family physician, this frailty index is automatically spit out. So, and they've actually looked at this specifically with perioperative mortality. So if patients had an EFI, if they were frail based on this EFI, their hazard ratio was 2.5 for 30-day readmission and almost 3 for 6-month all-cause death. So, pretty, relevant information to know going into surgery. And then another thing I wanted to look at, again, this isn't specifically about post-op delirium, but it just sort of ties in so nicely with frailty. Is there any evidence out there that identifying frailty may be sort of a surrogate marker for finding those same people that might be at post-op risk of post-op delirium? It does seem like that is the case. So they in this paper, they looked at the cognitive consequences of frailty in this cardiac surgery population, and they used the Freed frailty scale. So those 5 domains to identify non-frail, pre-frail, frail, and found in patients that were not frail, the incidence of delirium was only 13%. If those patients were, if patients were pre-frail or frail, it was actually around 50%. So over double risk of post-op delirium just by looking at frailty. This was another paper out authored by a few different people and Dr. Rockwood in 2021, and it was an observational study of about 1,700 older people, and really highlighted, yes, there really does seem to be a connection between physical frailty as a modifiable risk factor for dementia, or cognitive frailty, so to speak. So this found a frailty was strongly associated with dementia. So high frailty had nearly 4 times the risk for dementia. And as we know, pre-existing cognitive impairment or dementia is a very well-known risk factor for postoperative delirium. This is from the American Geriatric Society or College of Surgery guidelines here on post-op delirium as well. So they do mention frailty measurement, but they also do mention these multiple geriatric syndromes. So don't just look at frailty in isolation. They really do highlight, like, we also need to, look at cognition preoperatively as well. So the AGS guidelines recommend screening, as I said, for post-op delirium, things like visual and hearing impairment, pre-existing cognitive impairment, poor nutrition, poor functional status, polypharmacy. And they actually say frailty is a risk for post-op delirium. And again, this is best done in a comprehensive geriatric assessment. So what is a CGA? It is a usually interdisciplinary assessment done by a geriatrician, and whereby we develop a management plan for medical, cognitive, functional, psychosocial aspects of an older patient who has geriatric syndromes, including frailty. And as we saw, if someone has a CFS of 5 or above, CGA is sort of the recommended next step in the pathway, as per the American and British perioperative guidelines. And geriatricians are very, of course, well equipped to do this. It's just sort of an issue of manpower, especially in our province. So what is the evidence for CGA in a surgical population? There's actually quite strong evidence that it's very beneficial for patients. This was a Cochrane review in 2018 that shows a perioperative CGA reduced death in older people with hip fracture. They also found a CGA reduced discharge to a higher level of care. And CGA patients were more likely to return to the same location they lived in before hospital admission. They also found CGA lowered risk of delirium. And, it really, the challenge, this is time and resource intensive with limited geriatricians. So in conclusion, patients that see a geriatrician perioperatively die less, they're less likely to lose their independence and less likely to have delirium. And, I just want to compare this to sort of what's been standard of care for quite some time. This was a paper that came out this March in JAMA that showed, this was just a cohort study, but they did find actually a higher 30-day mortality, so 0.9% versus 0.7% in those patients who had a preoperative medical consultation. And there wasn't a reduction in adverse postoperative outcomes like delirium or loss of function. So to check in so far, we've defined frailty, the implications in a surgical population. We've looked at some major guidelines that do indicate we should be measuring frailty in a perioperative setting. The available evidence at this time does suggest frailty is a good surrogate marker to identify those at risk of post-op delirium. So by doing frailty screening, we would also, have that additional benefit. We looked at a comprehensive geriatric assessment recommended by the British guidelines to be done in those CFS 5 and above, that shows mortality benefit and some other beneficial outcomes. So next, we're going to look at what are some different ways of measuring frailty, and then what can we do now? Who would be best to do the screening? What kinds of tools should we use to screen? So I've got a few different tools here and sort of the evidence behind them to kind of help look at what might we use. As we just mentioned, the CGA is the gold standard to measure frailty, but access to a geriatrician in Canada currently doesn't allow us to see, everyone with a CFS over 5. The first one I wanted to look at as a frailty measurement tool is very simply timed up and go. So of those 4 frailty components, it's just looking at a measure of exercise capacity. It's very quick to do. It takes about a minute or two all you need is a chair and some masking tape and a stopwatch. So someone sits in a chair, they stand up, they walk 3 meters, they turn around, they return to sit down. This has been used as a frailty screening tool for a long, like since 1986. It's quick, it's simple, it's well validated in assessing functional mobility. So a slow timed up and go, defined as over 15 seconds, predicted increased post-op complications in 1 year mortality. And it actually, despite being so simple, performed better when compared to more complex risk calculators at forecasting post-op complications, regardless of what kind of surgery was done. Another study looked at geri-oncology patients that underwent surgery that showed a slow tug time identified double the number of patients at risk of post-op complications versus the ASA risk stratification alone. So despite being a pretty quick, simple thing to do, it does have fairly good evidence that, it can identify those at higher risk. And we'll get to the Edmonton Frail Scale a bit later, but this is one of the 9 frailty components measured in the EFS. So very similar to the timed up and go, gait speed is another thing that's been looked at in perioperative frailty measurement. So again, very quick to complete. All you need is some masking tape and a stopwatch. Dr. Affiolo showed in 2010 the value of gait speed. So we've known about this for quite some time. That gait speed is a very good surrogate marker for frailty and very good at predicting morbidity, mortality in the cardiac surgery population. And a slow gait speed is essentially defined like 0.8 meters per second is that sort of cutoff to remember. So if you can see here, those with a slow gait speed had a 43% risk of mortality or morbidity postoperatively versus people with a normal gait speed had, much, much lower risk of poor post-op outcomes. We did look at the Fried frailty phenotype. I won't go over it again. I just wanted to mention we don't generally use this in clinical practice simply because it needs a manometer to measure grip strength, which I do think they have available in some clinics, but it's not sort of widespread that these manometers are easy to find. So this is a very, quick 5-component one to do, but you would have to purchase equipment to do it. There's also something called an essential frailty tool set or EFT. This was looked at in coronary artery bypass surgery and also TAVI patients. So pre-op EFT score was done. It looks at, so the things it measures are timed chair rises. So just, standing up, sitting down from a chair. Cognitive impairment measured by an MMSE, serum albumin, and hemoglobin. So 2 of these things are just lab values. They looked at this in McGill, smaller study, 500 patients, but average age 71. These are people undergoing bypass. They found that each incremental EFT point was associated with a hazard ratio of about 1.3 for poor post-op outcomes, and frail patients had a 3-fold increase in all-cause mortality. So they found this EFT was a very fast, this is very quick to do tool. It's also highly prognostic to sort of guide decision-making on, things like bypass and aortic valve replacement. So yeah, it only takes 5 to 10 minutes, but the con is that it's not really looked at extensively outside the cardiac surgery population. So this is just a visual of what is the EFT. So those chair rises, MMSE, hemoglobin, albumin. And if you note here, so the 1-year mortality is 6% this is for TAVI. If you only have 0 or 1 point on the EFT, but if you have all 5 points, 65% 1-year mortality. This sort of helps guide, are we going to do more harm than good than putting this frail person through this procedure? So the Edmonton Frail Scale is another way frailty is measured. It's unique in that it goes beyond case finding. So the clinical frailty scale is really good at identifying who is frail and how severe is it, but it doesn't kind of go that next step of what are these components of frailty and how do we, take action on these individualized frailty domains. The one downside, the EFS can take a bit more time to do because it is more comprehensive. It includes a timed up and go and a clock draw test, but it likely is the best compromise of all these frailty measurement tools. In the absence of a CGA, this sort of gives us these components. So this EFS was developed by Dr. Rolfson out of Edmonton and validated in 2006. So the EFS, as you can see, there is a measure of cognition. So this could help us identify those, risk of post-op delirium. Overall, just general health or medical status. They look at functional independence. Is this someone who is, driving, doing their laundry, housekeeping, doing their own money, or is this someone who needs support with those things? They look at social frailty, which I think is quite unique and really good. Essentially, is there someone you could call if you needed help? Looks at polypharmacy. How many medications do you take? They use 5 or more as a cutoff for polypharmacy. Malnutrition, a question around mood, continence, and then they do the timed up and go. So that's the Edmonton Frailty Scale. And, it's nice that, someone has malnutrition, get the dietitian involved. If someone has polypharmacy, then your output is sort of, let's look at deprescribing. If someone has no one to call, social work referral. So it sort of guides you into what those next steps would be. So finally, the clinical frailty scale. This is, the most popular frailty measurement, I think, worldwide at this point. Very well known. There is a training course available on the Dalhousie website for clinical frailty scale. With practice, this can be done fairly quickly and has robust literature to support its use. And this is the tool that BGS, guidelines recommend perioperatively. The downsides or potential downsides to the CFS, it can be more prone to cutting corners or inaccurate scoring, something, called operator dependence. So if 3 different people measure CFS, they may be more likely to come up with different numbers or different scores if you don't take the time to collect the needed information. It also was originally validated in patients, so community dwelling, older people, after they had a CGA done. So based on the CGA, you have your functional, your ADL history, you have your cognitive testing and history. You've asked about geriatric syndromes like weight loss and exercise tolerance, falls, comorbidities, et cetera. So it's a high-level summary tool. It's a little more subjective than something, like a clock draw test or timed up and go. So again, this is a CFS 1 to 3 not frail, 4 to 9 frail. If you kind of look, what are they looking at here? So let's say someone with a CFS of 6. This is someone we would probably, if they were a 6, have to have a more in-depth what you might call a values-based assessment with surgery. What are they expecting with surgery? Is it likely to be achieved? What trade-offs is this person, willing to have in undergoing a surgery? Someone who's a CFS 6, they can't do any of their instrumental activities of daily living. So they're not driving, managing their money, their medications. They can't do things like grocery shopping, carrying heavy bags, or laundry. They might get short of breath, or their mobility might be too poor. And then they also are starting to need help with BADL, something like, needing a bath assist or needing help getting dressed. So if someone is having trouble getting dressed, you can imagine that something, as physiologically stressful as a surgery, those are people that really we need to be very cautious about. What are our goals? Are they likely to be achieved? And sort of have that discussion with the patient and their family. So the CFS is very good at case finding, but it's not meant to provide those next steps or actionable components. So as the British guidelines said, these are people, if they're identified as frail, they should go on to a CGA to look at things like exercise, prehab, nutrition, functional support, deprescribing, medical optimization. So that's kind of a summary of, there's quite a few different frailty measurement tools out there. The CFS is usually the one that's most commonly being used and recommended in guidelines. I wanted to just briefly talk about what are some things we could do now, and then open it up for discussion. So In measuring frailty, I just want to flag it's not just the pre-op setting, but there's also things we can do intraoperatively and post-operatively. In places like Toronto, they have like beautiful pathways developed for, these more vulnerable older people. So pre-operatively, frailty case finding via the CFS. Um, that would identify people that would benefit from CGA. Edmonton Frail Scale could also be done that would provide some of those actionable frailty components and is probably the best measurement tool in the absence of being able to do CGA on everyone. If people are frail, we look at these so-called defrailing interventions like exercise, prehab, medical optimization, nutrition, deprescribing, early discharge planning and allied health support. It helps us identify or case find these people at increased risk of post-op delirium. So doing things like a mini cog, which is a 5-point test whereby people draw a clock and then have 3-word delayed recall, or clock draw. This isn't a robust cognitive assessment by any means, but it's a screening tool to identify, people at potential higher risk. If there is significant cognitive impairment or, at least moderate or severe frailty, CFS 6 and above, these are people, as I said, we need to be really sort of clear on what are we looking to achieve with this procedure. In time, if we identify these people, we could have a perioperative delirium order set, do things like make sure the family or substitute decision maker is involved with postoperative instructions, like, ostomy management. If someone has cognitive impairment, then that would be, good to know early. So that's, sort of things we could do preoperatively. Intraoperatively, there are some things that we could do if someone's frail, let's say they're CFS of 5 or 6, we identify we do still want to proceed with this procedure. Things like trying to get them in the first case of the day to minimize how long they're fasting. Just a quick review of some of the evidence. This is more so post-op delirium, but GA versus regional anesthesia hasn't strongly been found to make a difference in the literature for post-op delirium. There was a systematic review done looking at this intraoperative EEG monitoring to measure the depth of sedation and, try to use less overall sedation. They found it wasn't strong evidence, but this may reduce delirium based on this review of the evidence. And then Precedex or Dex, you guys are going to laugh at me for trying to say this, dexmedetomidine may have a slight edge over some other medications for post-op delirium. Another thing that's done in some other centers, so anesthesia will sort of notify the geriatrician or can consult the geriatrician in the hospital from recovery room if they're sort of worried about this person. This looks like someone, that is high risk for delirium. Other things that can be done, like less invasive surgical techniques. One example, the anterior approach for total hip arthroplasty does have reduced recovery time than the traditional posterior approach. Trying to reduce other things that can be associated with post-op delirium, like opioids. So perioperative pain management strategies like peripheral nerve blocks do have some evidence that they have benefits. So there was a Cochrane review in 2020 looking at peripheral nerve block in hip fracture patients, and they found there was less delirium and a shorter time before first ambulation or mobilization for those patients. Post-operatively, there's, again, lots that we can do for these people. So some of you may have heard of ERAS or enhanced recovery after surgery. They have these whole surgical bundles of care that they look at, evidence for things like surgical site infections, nutrition, avoiding prolonged fasting, multimodal pain management, trying to avoid deliriogenic medications. Early mobilization is a big one ERAS focuses on. So these are sort of, surgical bundles that are done, at AHS. Like, for example, we had a pathway for ERAS for colorectal surgery patients. But post-operatively, that's where a lot of this delirium prevention can also come in with early mobilization, getting, physio, occupational therapy, registered dietitian involved early, having the patient, start mobilizing as soon as we can. Ideally have physio on post-op day 1, minimizing opioids, other deliriogenic meds like antipsychotics, benzos, gravel, getting that fully out as soon as we can. It's a risk of infection and also kind of acts as a 1-point restraint for mobilizing. using hearing aids and glasses, having family there, and then getting that discharge planning started early to try to reduce, readmission. So what benefit would there be to patients in measuring frailty? It would better allow them and their families to make informed decisions around the risks and benefits of surgery, especially, given these potentially life-changing consequences that we see all the time, like loss of functional independence or mobility and post-op delirium. It would allow us as providers to identify those that need kind of special attention and try to mitigate risks, ahead of the game. So instead of waiting until they already happen, we could try to, intervene a little earlier. So I'll talk about prehab shortly. There are, of course, some barriers to prehab or pre operative exercise interventions, optimizing nutrition. If cognitive impairment, there's certain things we can do. If severely frail, if someone has a CFS of 7, meaning, they can't walk on their own, they're confined to bed or wheelchair, they might be incontinent, can't feed themselves. Those are people, if they're going in for a surgical procedure, we really need to be cautious. Like, are we going to harm this person more and shorten their life by putting someone with no physiological reserves through a surgery? Or, what does a patient and their family understand and expect with a surgery? And then by flagging and identifying these people, as I mentioned, we can sort of look at these perioperative delirium prevention strategies we talked about in the last slide. So, in operationalizing this, can CGA sort of be done perioperatively without geriatricians? And, this study looked at some of these clinical toolkits that were designed to empower perioperative teams to do CGA or its components in places they didn't have a geriatrician. And unfortunately, it didn't have similar outcomes. So really the conclusion is there has to be a geriatrician embedded somewhere in the periop care pathway, and the more geriatricians, the better. What about prehabilitation or exercise before surgery? So, as much as this is difficult to do, given things like, by the time we're seeing them, the surgical date might already be set in a week or two. There's not a lot of time for this, but I still need to, mention exercise is the number one intervention we have to reverse frailty. So in the mild and moderate stages, frailty can be a dynamic syndrome whereby we can improve patients' functional status or reduce their level of frailty. But ideally for prehab, it's a structured program. It's at least 2 to 3 times a week, 30 minutes. And 12 weeks seems to be an ideal amount of time. And we often don't have 12 weeks before surgery by the time we identify patients. But in Saskatoon here, like we do have a variety of rehab sites. Like the Field House has both cardiac and pulmonary rehab programs. They also have the Fit Over 50 program that you don't need a referral. Patients can go there, or we could recommend it to them. But there's lots of other barriers, but other than just like the time frame between the surgical date already being set. Things like patient fatigue, which is, a defining feature of frailty, their baseline health issues, they have sore knees, they're, say going in for a joint replacement. It's hard to exercise when you're in so much pain that you need a new joint. Weather, both hot and cold, and then transportation. Prehab, there is not a huge number of sort of randomized control trials out there. A systematic review found about 178 RCTs looking at prehab interventions. So these varied between exercise, nutrition, inspiratory muscle training, multimodal interventions. They did find that overall this may reduce post-op length of stay and complications like infection and pneumonia. Just a shout out in Canada, there is the AIMS research group based out of Ottawa. They're currently they're enrolling people for the PREPARE trial, so an ongoing RCT for prehab in Canadian population. So something to watch out for in the next few years, the results of this trial. So how do we do this now? There are system level challenges and logistics to this. So, in PAC and Saskatoon, I know there's, at least a couple dozen patients going through there each day. There's a limited number of geriatricians. Oftentimes, by the time patients are seen at PAC, their OR date is often set. So we don't have a lot of time for sort of implementation of things that may modify their level of post-op risk. And then some sort of or considerations with frailty. So when and who should be looking at this. For the when, the earlier the better. So, what we call proactive case finding for CGA. If we screen someone positive for frailty, then ideally CGA is the best next step. So, in that earlier pathway, that would be more so patients referring family physicians that, could identify even like a clinical frailty scale or have some measure of their cognition, like a mini cog in the office. These are things that are pretty quick to do. And if that could be incorporated in sort of the preoperative evaluation form, maybe we could direct some of these patients for CGA a little earlier. We also could see people in PAC or post-operatively, but the earlier we see people, the more lead time we have for interventions. And then who should measure it? So, really anyone can do these things. You just have to make sure that you're consistent and doing it, not like once or twice a year. Like the more you use these tools, of course, the more quickly you can do them and the more accurately. So if someone is going to measure the CFS or, for example, the Edmonton Frail Scale, I put the links here for these freely accessible training guides for them. And the CFS one, I think is, pretty quick, like 15 minutes or so. The EFS one is a little more extensive. So someone is doing this. We just want to make sure there isn't that operator dependence, that it's ideally the same handful of people or people that do these things, on a fairly regular basis. So I'm curious, to open this up to discussion quickly here, but I personally would advocate for some measure of frailty, cognition, and nutrition. So something like a CFS mini cog nutrition screen, those are pretty quick things to do and are more targeted to, these negative post-op outcomes we want to avoid, within the perioperative assessments. Another thing we could do as we looked at the evidence for timed up and go and gait speed, these are just very objective, simple things, that can be done fairly quickly and are very good surrogate markers for these more complicated, measurement tools. If someone has slow gait speed or timed up and go, a pre-op referral for physio OT or flagging them for therapy post-op day one. Another thing in Saskatoon, we have our geriatric day hospital program at City. That is a really good structured program for prehab, cognition, deprescribing, medical optimization. We sort of have the whole team and consult geriatricians when needed. The trouble, though, again, is the timing. So, there's a few month wait list often for the day hospital. And then the program, usually people go twice a week for 6 or 8 weeks. So if a surgical date is already set, that may not be an option. Another option, we could have the patient or family member fill out some of this information in PAC, like these simple 3 questions. Do you use a mobility aid? If someone's using a cane or walker, they're probably a CFS 4, 5, 6. Have you had a fall in the last 12 months? Falls being a marker of sarcopenia, immobility, decreased exercise capacity. And, do you or your family member have cognitive impairment? So that, is also an option. We could look at having the family member or patient fill some of this out. Ideally, as I said, we could offer more formalized geriatrician consults for CGAs for complex cases soon. This is something I'm quite interested in doing, and we're, within the next year or so, actually going to be fortunate to hire more geriatricians in Saskatoon. So likely we'll be able to expand what we can offer here. In time, I do think it'd be good to develop an inpatient delirium protocol or order set to be kind of filled out for those that screen. Again, these aren't extensive. This isn't meant to diagnose dementia, but if someone has an abnormal clock or mini cog, then, filling out that post-op delirium protocol in PAC may be something that would be beneficial. This is an area that really bodes well for collaborative care models. So, having sort of a joint group of geriatrician, anesthesia, geri psych, surgery, internal medicine, family medicine, allied health. I think it'd be really great to develop sort of a group to look at like, what is feasible for us to do at our specific site and when, and how do we implement this? Because it likely will be site specific. Um, Another option, as I said, so anesthesia in some settings can consult the geriatrician or just give us a call from the recovery room. So people that are over 70, they might have, hearing, visual impairments, dementia, MCI already known. Then at RUH, certainly I would have capacity to see, a couple people a week through that route. And then, future state, I think when we, sort of look at more specifics, we could look at piloting like a patient or two per month to start with, to be seen for CGA, within PAC. So I'll just talk about the case quickly. I also have some information about, what do they do elsewhere? I'm happy to chat about. So this gentleman who 71-year-old with diabetes, BPH, smoker, MCI, hearing loss, esophageal adenocarcinoma, esophagectomy. So when we did an assessment, we found his pre-op CFS was 5 and mini-cog was 3 out of 5. So kind of screening both positive for frailty, vulnerability, and cognitive, red flag for post-op delirium. The pressure ulcer probably was not overly surprising given his significant weight loss and malnourished state. Pneumonia as a smoker and just the location of the surgery and the pain, it isn't overly surprising. Inadequate oral intake with the NG feeds and the nausea from ileus. Using all these medications like gravel as an anticholinergic makes ileus worse. Amitriptyline, had we stopped that preoperatively, it has quite a profound effect on bowel motility. We may have been able to at least reduce that risk. And then also these extraneous tubes and stuff, if someone already is cognitively impaired, we want to avoid that as much as possible, because the downside of Foley's and NGs is people are restrained, tied down for, 24/7, essentially, as long as these tubes are in. And then, the delirium, again, probably predictable given all his risk factors, and anticholinergic medication use, when you combine that with BPH, isn't surprising that there was urinary retention. So what could we have done differently? Had we had a little bit more lead time with that anemia, hemoglobin of 80, maybe we could have, and this is something we can do through day hospital, get people in for IV iron infusions, try to optimize his hemoglobin preoperatively. Could have talked to him about smoking cessation, even a week or two before surgery, getting nicotine patch, etc. May have helped with the post-op pneumonia. Nutritional status. So in patients undergoing surgical procedures, there's something called the PROTAGE study groups, so protein with age, essentially. And they make evidence-based recommendations for protein intake on older people. And for people that are malnourished to begin with and undergoing, tissue trauma that you require healing for, they actually recommend quite a bit of protein. So 1.5 gram per kilogram per day. So I'm not saying that we would do this for every patient, but I have seen in certain cases, patients get admitted a week or so beforehand for preoperative nutritional optimization. With something like TPN, risks of candidemia versus NG tube, you're tying someone down 24/7, you're going to make them delirious, increased risk of bed sores. So, we could have at least initiated that conversation to see if we could avoid, the pressure sore and post-op delirium. We could have stopped the amitriptyline, which would have reduced risk of delirium, ileus, urinary retention. Could have tried to get him scheduled as early as possible. And then talk to family about, that he does have an increased risk of delirium. They need to be there at the bedside as much as they can, advocate to have him up in the chair, reorient, bring in newspapers, use those hearing aids, try to advocate for mobilization. Those are all things we could have, sort of flagged preoperatively. And then post-operatively, things like asking for an airbed, turning, repositioning to with the risk of pressure sore, trying to get physiotherapy in the first 24 hours, and then avoiding those deliriogenic drugs. Like, in my opinion, gravel should not be on any order set for any older person. The razapam, haloperidol, all increase risk of delirium. We could have tried to avoid some of the opioid scheduling, around the clock Tylenol, doing things like bowel care, melatonin, using an intermittent cath as opposed to an indwelling Foley. So there's a lot of things, I guess, with this particular case we could have done a little differently to try to reduce this gentleman's risk. So that's what I have. I'm happy to open it up for discussion. And sorry, I'll just check the chat box. Absolutely, Dr. Thorpe. I think day hospital would be great for some of these patients if we have the lead time, and we are soon to have more geriatricians, and I'm quite excited about that.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.